economically, healthcare it's extremely expensive, and we aren't necessarily getting out of it what we think. So this is an extremely small graph, but the thing that you really need to pick out here is that here's the United States. This data is from 2008, but it's continuing to be about the same. So here we are, United States, spending more money than any other country in the world per person on our healthcare, almost $5,000 per person back in 2008, and yet we aren't achieving extra life. There are a number of different pieces of information. This one we're looking at life expectancy, and you can see that we're not living longer than, say, Japan, who spends only half as much per person on healthcare. Same is true if you graph infant mortality. We actually have a pretty high infant mortality rate in this country, and these things that you would think, we're putting so much money into our healthcare, we should be really healthy, we should be living a long time, and we should be living well, and we aren't necessarily doing that. So that's one component of this sustainability question. Socially, there's been inequitable access to health care for a number of reasons, and that, is somewhat, well, it's definitely a policy issue, and it's something that people have been trying to overcome with new, some of the new policies that have been implemented and are being implemented in the state of Vermont. Lots of talk about how to get better access to care, but definitely a problem for sustainability. And then environmentally, people have started looking at this. There are a few places, Healthcare Without Harm and Practice Green Health are two national, international organizations that are trying to kind of compete or take away the problems of healthcare that are causing ill health to people outside of the hospital. So they look at things so far like pushing green building. If you're going to build a new hospital, make it green. Decrease the amount of energy. Hospitals use they're the second highest user of energy per square foot compared to hotels are number one. So they're using a lot of energy. They're open 24 hours a day, 7 days a week, and they're just lots of people in and out. Food is a huge issue. Hospital food, everybody knows the connotation of hospital food. It's not very good, and it's definitely not local, sustainable, organic, none of those things in a lot of places. Though here at Fletcher Allen, there's actually a really good food system going on here.
Healthy food in a hospital, that's a bad business model.
I know. Well, yeah, absolutely, and that's kind of one of the questions of the whole system itself. In a way, we're really making people outside of the walls of the hospital sick in a lot of ways, and wow, we're kind of doing that, and we're creating business for ourselves in the hospital. It's kind of an ethical question for sure. So these places practice green health, healthcare without harm, have kind of been looking at certain aspects of the impacts that hospitals and medicine has on this larger picture, but they haven't really looked at the practice of medicine, and that's what I have been doing, actually going in and shadowing physicians and nurses and pharmacists and administrators and trying to understand what is it that's driving this system at the patient level for decision making, and what are the specific impacts that that practice of medicine has on the environment and on human health. And of course, when you look at these environmental aspects, you'll see that there's going to be a direct link to the cost, because we're generating a lot of waste, and it's just skyrocketing the costs of things. We'll talk about that more as we get into the data that I have collected. And then there's a huge impact on the health of workers and communities outside of the hospital, and that's definitely a social component of the sustainability question. Why focus on end-of-life medicine? All right, this is a really strange area for people to be interested in. If you think about it, you're really looking at people who are dying, what's going into dying care. So the way that somebody gets into a strange question like this is to go through a personal experience. My dad died 12 years ago of cancer. He was an organic dairy farmer. I was an environmental studies major at the time. We had a lot of conversations. What's going on here? Lots of chemo going on. Transitioned through to hospice care eventually. We didn't have a very good experience through this whole process, and we really were starting to question what is going on here, and that question stuck with me for, gosh, how many years? It was 8 years later when I finally went for the PhD and asked this question, and I brought it up to my advisor. I was actually planning on studying food systems, And I told this idea to my advisor, and he said, that sounds really interesting. Let's take a look at this. Write up 2 pages of a little report and see if there's anything here. Put it together and said, wow, there's actually a lot here that could be really interesting. So that's how, personally, I got involved in this question. But when I wrote up that little piece of paper for him, these are some of the things that we started to find. So end-of-life medicine, it's really expensive. You think of healthcare as being expensive. Dying is the most expensive part of healthcare. 30% of Medicare expenditure is going to only 5% of patients. Your end-of-life care, which is typically about 2 years worth of cost, count for 18% of your total lifetime cost. And the closer you get to death, the higher the costs escalate. And it goes up month by month by month. That final year, the final month, the final day, you're skyrocketing. So really expensive because we're really churning in a lot of material resources into that care to try to keep that person alive. But the cost doesn't equal a different outcome. We're putting all that money in, and we're not staying alive longer, and we don't have a better quality of life. So in comparison between conventional patients and palliative care, I'll tell you a little bit more about what palliative care is, but a hospice is one example of palliative care. Folks who stay in conventional do not have a higher quality of life, even though they're getting a lot more inputs. And that's probably, from my observations, it's all the inputs that are decreasing your quality of life. You really can't enjoy anything anymore because there are so many tubes going into your body, you can't get up out of your bed. So we have these 3 models of end-of-life care in the United States. Conventional care, hospice, and palliative care. And this is kind of how they developed, just a brief history. Before the 1930s, we all died at home, pretty much. And then we had this pretty big social transition where people stopped living with their families and started moving for job purposes. Cities were getting bigger. People were moving away from the farm and going to work in the factories and all that sort of thing. And because of that, you didn't have your family there to take care of you anymore. So we started transitioning the dying into hospitals. And we also had a lot of those technological advancements from World War II. Chemotherapies are one example of things that we started having the ability to lengthen life through ventilators, things like that. So we really started shifting people to the hospital. In the late 60s, the first sociological studies were done on this, and they started questioning, well, are these people dying well? And really discovered that, wow, no, people are really not dying well. They don't know that they're even dying. Patients they're not told by the physicians and nurses that they're dying. And that was a huge problem because it left people isolated and in pain because they were not being cared for in an appropriate way for the end of life. They weren't getting the amount of narcotics that are necessary to really control pain when you're dying. So in response, hospice came on board. The first modern hospice was in London in the early 70s, and then the first hospice in the United States was in Connecticut after this woman, Florence Wald, went over to London and studied at the St. Christopher's Hospice, which was the first, and she brought her knowledge back and she formed this Connecticut hospice. And from there, it really skyrocketed and has just grown exponentially across the country to the point now where we have nonprofit and for-profit hospices. And that's another question that I have not looked into myself yet in terms of differences between nonprofit and for-profit. You'll see the hospice that I was at was a nonprofit hospice, and it might be very different in terms of the care and the impacts that are happening. The success of those early hospices led to Medicare allowing for hospice to be covered at the end of life. And pretty much once you are determined to, if your physician says, I would not be surprised that if you died in the next 6 months, that's when you're eligible for hospice care. It doesn't mean you have to die within 6 months. And we'll talk about that a little bit more later too. Yes?
full care like rest homes, does that fall into conventional care or hospice or something in the middle?
Like nursing homes.
Nursing homes that have full like nursing
Sure.
staff.
So that can be any of these things. You can get hospice care in a nursing home. You can be getting conventional care in a nursing home in terms of what if you're in a nursing home and you need conventional acute care, you would go to the hospital. If you're in hospice and you need and you need acute care, you might end up going to the hospital still, but you'll be under hospice care. There's a lot of overlap between these different models and where you end up physically, but the philosophies are different throughout your care. So it's more philosophical differences than actual place differences. That answers your question. Okay. Palliative care is kind of a blanket statement. Hospice is a form of palliative care. Palliative care basically means providing comfort instead of cure. So conventional is cure, palliative care is comfort. Hospice is one form of palliative care, but hospitals have started offering their own palliative care services because not all patients are making it into hospice, and because there's a need for patients to get comfort care as they're transitioning from conventional into lower aggressive treatments. And so palliative care has become its own medical specialty. Within just the past few years, there has been a push for more training for palliative care specifically, and Chuck probably knows more about the training specifics of it than I do. But the Institute of Medicine, IOM, they did a study, Approaching Death in '97, which was kind of another look at, have we succeeded, now that we have hospice care, have we succeeded in helping patients so they aren't dying in isolation and in pain? And they decided that actually hospice hasn't done enough because it's outside of the system. We need something that's inside of the hospital, the healthcare system itself, that will help improve patients' pain and quality of life. So palliative care became the specialty within the hospital itself. Did I explain that clearly enough? Yeah.
I remember I was at one hospital and they had a hospice within the hospital. Is that kind of, it's just sometimes they just kind of have different names, but it's kind of the same.
Yeah, and there can be, there are so many different models that there can be a hospice right within the hospital.
Yeah.
And it's a form of palliative care. They might also have a palliative care specialty or service that helps transition people from conventional into the hospice, but it could all be within that same institution. Again, it's kind of philosophy versus
Just not like a
physical
real
space.
standardization of it. It's just kind
Right.
of what.
It's kind of lots of different options. Yeah, which makes it a little confusing and kind of hard to follow. So because we have these three options, we also have a really nice setup for a study comparing these three options. So we have hospice care, which is this comfort care. Palliative care, which is mainly it's hospital-based units that are trying to help transition folks who have life-limiting illnesses away from aggressive care and into comfort care. And then we have this conventional care. And through these three, that's where you have the increasing costs. I wish I had at the top of my head the difference in cost between these three. It's huge. Hospice care is, if I'm remembering correctly, this is data that's about 2 years old now, so it's probably changed. Hospice care is about $5,000 less for the final month of care than palliative care. Palliative care is about $7,000 less for the final month from conventional. So there's a difference in about $12,000 per month between hospice and conventional care, if I have that data correct. So typically it's thought that the lower cost is reflecting fewer material inputs. But the question is, for me, does that equal lower ecological and human health impacts? So next step, what population to choose? I chose cancer patients, a number of reasons. You know, what is it? 1 in is it 50% of people now will have some cancer in their life? It's either 50 or 1 in 2 or 1 in 3 people will have cancer of some sort. It won't kill you necessarily, but you'll have cancer. So the question is, what's my cancer going to be, right? Everybody's going to have it. And human health impacts, and we'll talk about those more specifically. Chemotherapy in particular, nurses handling chemotherapy have higher rates of miscarriage. Their children have higher rates of certain illnesses. The nurses themselves have high rates of leukemia. So just handling these things or being exposed to them, and you can get sick from it. Surgery, you have a lot of infectious waste. Where does that go? What happens to it? Who is handling it along the way? And then radiation is something that I didn't encounter very often. I only had encountered 2 patients on the unit where I was that were having seeded radiation, so it's something is put into your body and is giving off radiation. And those were really interesting patients and cases for me, because the housekeepers were responsible for, cleaning out the room every day, and they had to wear the little Geiger counters when they went into the room to see how much radiation they were being exposed to. So definitely a cause for some sort of occupational concern. They're being monitored very closely, but it's kind of a question. Palliative care, definitely lower on the material use, and then hospice, the comfort care. Hospice was actually, the modern hospices were developed specifically for cancer patients. So here we are. This is my study, multi-sided ethnography. I had these 3 units where I was. The conventional and palliative care units were both in a teaching hospital, and they were kind of married to each other. The palliative care unit had grown out of the conventional cancer unit. And then we had this standalone nonprofit hospice organization. So over the course of 2 years, I shadowed 54 different people for 255 hours. And then I interviewed a number of those folks for a total of 36 hours, and also gathered some institutional data to get some of the quantifiable information as compared to the qualitative information.
So did you look at all to see how the hospice you're at, or teaching hospital you're at, to see if it was kind of representative of the hospital as a whole, or how representative it is? Maybe there's not a representative sample, but...
That's a very good question. It's a very difficult question to answer, because there are so many hospitals. This was an average, it's comparable to other hospitals that are within that area, and so this was in the Midwest where I was doing this study. Hospitals of this size, teaching hospitals, you can't compare my information to other types of hospitals, because the physicians here were salaried, so you didn't have, it was tricky asking the physicians about, well, I've heard that, it might be possible that physicians are getting, kind of paid per procedure. Do you think that plays a role? Oh, no. Well, I've heard of that too, but no. Well, actually, no, because I'm salaried, so I don't even have to worry about that. So everyone had heard of this happening, but it wasn't happening here as far as we could gather data.
So other hospitals were on a different model with non-salaries, so it's...
Exactly. So it's comparable to a very specific type of hospital. Yeah.
There's a disconnect between how much you're paid and how much the hospital gets reimbursed. So hospitals are encouraged to do procedures or tests and that sort of thing because they get reimbursement for that. So while you miss me making money, you're still supporting the hospital.
And you may be pushed in that way towards having more procedures done. Yes, thank you, Chuck. All right, so this is kind of the data that I collected.
I'm sorry, I had a quick question.
Yes.
Participants were physicians?
We had physicians, nurses, administrators, and pharmacists. And then a few people who were kind of a little further downstream, so the waste handlers, trying to follow a few of the flows of where things were going. And I had 3 guiding questions, the basics. What's the environmental impact here? What's the human health impact from this type of care? How do these impacts differ between these 3 places? And then what is driving the system? What is the governance here? And this is the question I think you guys will be most interested in. So for that first question, what were the impacts that I saw? And we came down to 3 specific areas of impact. The first is medical supplies, just in general. Where are they coming from? Where are they going? And then do those things matter when you're buying them? So procurement, the purchasing, do the purchasers know anything about the environmental impacts? There are a lot of programs out there now for environmentally preferred purchasing. The places that I worked at never heard of this thing before. So they had a lot of PVC coming into the hospitals. There are lots of alternatives now. There are some huge implications for PVC in terms of the people who are manufacturing these things are exposed. Well, back in the 70s, a number of interesting things were happening. A lot of the PVC workers were getting angiosarcoma of the liver, so they were getting their own type of cancer. Very specific population, little clusters, and because of that, the United States put into place a number of regulations. OSHA kind of was driven in part by what was going on here. So in the United States now, PVC workers are at least better protected. There are lots of standards in place for protecting people. But the majority of the PVC supplies in the hospitals where I was working don't come from the United States. It's impossible to know what the standards are in the other places. So are people being protected in Costa Rica, in Indonesia, in all these other places where they're coming from? I don't know. It's really difficult to know.
One question, was point of origin at all in terms of where the products came from in their decision set?
Not at all,
Okay.
no. The 2 decisions that purchases were made upon were, first, is it clinically appropriate? So is this piece of tubing the thing that's going to work for what we need? And is this piece of tubing the cheapest one we can get? So those were the concerns. And it makes sense when you have a business model. You need something that works, and you need to be able to make a profit on it. How do you get that environmental consciousness into the system is the question. The next area that we found were these occupational and community exposures to things. So the nurses who are exposed to chemotherapy. On the units where I was, this was a huge problem because a lot of other hospitals had at this time put into place, you have this chemotherapy bag. You need to somehow put the tubing in it so that you can deliver it into the patient's arm. A lot of hospitals put into place a controlled safety mechanism where it was a pharmacist actually spiking the bag is what they call it. You needed to have a little sharp instrument to plug that tube into the bag. A pharmacist was doing this in a hood so that there wouldn't be spray all over the place in a lot of hospitals. Where I was, the nurses were standing right next to the patient's bed and doing this. This was just their standard practice. And a lot of nurses were concerned about this because there had been times when one nurse in particular had spiked a bag and done it incorrectly. She was in a hurry, and the whole bag just sprayed everywhere. Now you have a hazardous substance. Right on any chemotherapy bag, there's the little orange sticker with the biohazard symbol on it. This is a hazardous substance. Now she has it all over herself. She has on a protective gown, which is made of paper with a thin layer of plastic in it. So she said, this is the quote that I'm remembering, "I gathered it up into myself and tried to roll it up and called for another nurse to come and help me." They had to clean up the chemo that had fallen on the floor in the patient's room and on the patient's bed and probably on the patient themselves. So this is kind of an interesting question. The patient is the one who's getting the chemotherapy. They need the chemotherapy, but they need it in them, not on them. So they're kind of being exposed in a strange way to these chemicals as well. It's not being delivered to them, it's being sprayed upon them. What is the impact of that? And maybe more importantly, what is the impact when their loved one comes to visit them and they give a hug, and now the chemo can travel that way, so you may be spreading these things. It didn't happen very often that the bags were being spiked and the stuff was going everywhere, but it happened twice while I was on the unit. So that's enough. That's enough to cause concern. Other exposures that were particularly interesting to me, when I was working with some of the waste handlers further down the line, so for infectious waste, 2 interesting things. Nobody on the units knows where any of the waste goes. You ask them, where does it go? I don't know, it goes away, right? And that's what we think of our garbage. It goes away, it goes somewhere. There's a landfill somewhere that takes it. So infectious waste in this particular community, and this is another thing that's not necessarily comparable, because here, infectious waste went to a local hauler and handler that would first steam the waste to 280 degrees for a certain amount of time. And that would supposedly kill the pathogens. After that, it was taken and put in this big hopper that would send it down into a grinder. It would get ground up. It would go up through this chute where it was microwaved 6 times in a row. And then it was this fine shredded dry material. And would go into a dumpster, and it was landfilled in the municipal landfill because now it's considered safe and clean. So the problem happens when something gets into, it's the red bags, or the infectious waste, when something goes in the red bag that shouldn't be in there. And the waste handlers at this place that I was, talking to them, what are your concerns for yourselves? Well, every once in a while we'll find a metal hip joint. Somebody's getting a hip replaced, surgery. Somebody just tosses the hip joint into the infectious waste thinking that it goes there. It does not go there. It actually could be recycled, which is kind of interesting. So this hip joint gets in here, and now it goes through the steaming system, and it's supposedly clean. You put it in the hopper, and now it goes through this grinder, and the grinder can't handle it because it's this large metal ball. The grinder stops. Now you have a bunch of bags of red waste sitting on top of this hopper, and one of those workers has to actually physically go down in there to pull it out. I know, I was like,
Talk about a bad job.
No, I know, how awful. They are protected by OSHA in terms of the gear that they have on, but still, the administrator for this place was particularly concerned, well, how do you know that everything is definitely killed? It's the regulation to have it at 280 degrees for X number of minutes. We've done that. It's probably safe. But would you want to go down in there? I don't know. Particularly since there are a lot of sharps in there now too. So the people have on their gear, but it's not necessarily completely protecting them. So what they had done instead to protect themselves was to start looking at the bags kind of individually as they're putting them into the steamer. If there is any reason for concern that there might be something in there, a stapler thing, people will just throw things in here that shouldn't be in here at all. There might be a stapler, there might be something metal in here that shouldn't be in here. We're going to open that bag up before it even gets steamed. We're going to look in there, and we're going to pull out the item that we think shouldn't be in there that's going to cause us a problem further down the stream. Because at least we are knowledgeable about what is happening, and we're more able to control the environment at that time. So they had put some steps into place to protect themselves. And yet, the real problem is that something is getting in the bag that shouldn't be in there. And that's definitely a governance issue. We'll talk about that a little bit down the line. And then the third area of interest was pharmaceutical control and disposal practices. And this mainly revolves around the Drug Enforcement Act and making sure that narcotics do not end up in people's hands on the black market or just being used inappropriately. And so, did you have a question?
Oh, did you, maybe you're getting some of it, but did you read anything about preventing it from getting into the water supply? Because I heard there's a whole bunch of pharmaceuticals and water supplies in different areas. It's
Yeah.
scary.
Yeah, that's part 2, absolutely. So at the hospital, everything is sent into hazardous waste and is incinerated and disposed of that way. At the hospice, they were more concerned about the DEA. The quote from the pharmacist was, "The DEA scares us more. They have guns and can fine you. The EPA, they don't really regulate." So they were dumping all of their narcotics in particular down the drain, which truthfully is not too big of a problem because the narcotics are metabolized really quickly in the water. But the problem more so was that at the in-home setting, so where I was in the facility. At the in-home setting, the nurses were trained to help, after a patient has died, they're trained to help the family, get rid of as much stuff that they don't need as possible, and that was all the drugs. And there are so many drugs. It's this huge cocktail. 25 drugs a person sometimes, different types of drugs, and multiple pills. They were trained to dump all of that in the toilet. It all went down the drain because they couldn't transport it in their cars. They didn't have enough space to bring it back to the facility to dispose of it through the hazardous waste, which is what they did at the facility for everything except for the narcotics. So a lot of stuff is ending up in the wastewater, and that's a huge public health question. There's one scientist at, I think it's USGS, his name is Chris Doughton, who is doing a lot of work on this. But, you know, the question is not so much what does one individual drug, what is the problem with that, but it's more so what happens when you have this huge cocktail of drugs in the wastewater and they're not filtered out through our wastewater treatment plants. There are a few wastewater treatment plants in the Middle East and in Germany that have started to be able to implement new forms of filtering, but we don't have that here in the United States yet. At least not in this area in particular. So, huge question. How do these differences differ between my 3 sites? So, for the institutional data, because the palliative care and conventional units were kind of married to each other within the hospital, they were one cost unit. So the data that I got from them was for both of those places. So when you see this list, I'm just going to point out the top one because it's pretty clear and interesting to me. Medical gloves, you're using 67 gloves per patient per day in the conventional and palliative care units. You're using 2 pairs of gloves in comparison in hospice. And it's a difference of practice. You are a nurse or a physician, particularly the nurses who are doing a lot of the hands-on care. As soon as you think you're going to go into a room, you grab a pair of gloves, you walk in there, and then it's determined that, oh, actually you need to get something else first. So you take the gloves off. You've never even touched the patient. You just throw them away immediately. You have to go and get something else. You come back, you put on a new set of gloves. You go in and out gloves, more and more and more. At the hospice, their motto was, there's no emergency in hospice, which is part of the philosophy. It's part of more of like this calm approach to the patient. What does the patient need? What can I do for this patient? You go in, you assess the situation, you determine what you need, then you put on your gloves if you need them. A lot of times they don't need them, and so they just didn't use gloves, only when medically appropriate. How to kind of figure out the difference between conventional and palliative care. That's when we look at the ethnographic data. I love qualitative data for so many reasons. You can quantify qualitative data sometimes. It's great. So looking at, I chose intravenous bags, the PVC bags, as a particular, I thought it was particularly helpful to look at this information because it suggests a whole number of other materials that are going in. When you have an IV bag, you also have the tubing. You have to change it every 3 days based upon infection control standards and that sort of thing. So in conventional, you're using about 2.5 IV bags per patient per day. For palliative care, it's a little under 1 bag. And then in hospice, it's 0.07 on average per patient per day. They aren't using as many of the dripping drugs in hospice. So there's a huge difference in the materials that are going in. And I have a great quote I did not include here. I should probably put it in here. Or maybe it is here. Oh, it is here. Here's the quote. Conventional care means more of everything. So the more of everything that you're doing, the more waste that you're generating. But it's also indicative of the amount of materials that are going in. And in this chart, we're looking at just the amount of waste that is coming out of these different places. And basically, if you see that total, 30 pounds of garbage of different types per day per patient in conventional and palliative care compared to half that amount in hospice. So there's still a lot. The average per person in their own home is about 6 to 7 pounds of garbage per day that we're creating, including recycling. So it's double the amount that you would be generating if you were just sitting around at home. So there's a lot of waste coming out of these places. Infectious waste, obviously much higher in conventional and palliative care because you have a lot more, surgeries and things like that going on in the hospital. Pharmaceutical use, much higher in conventional care, over double the amount of medications that are being used. Yes?
Yeah, I've got a couple questions building. So, in between the conventional hospice care, how is that decision, where is that decision happening? That's the patients deciding?
For,
Choosing which they're gonna be in, the conventional, in the palliative, in the hospice?
that's the biggest governance factor that I found. The patient can ask for palliative care, but they don't know about it or they don't know what it can do for them. Yes?
Because quite a few slides ago when you were talking about some of the costs, but what came up to my mind was when they were having the big healthcare debate, was especially with Medicare, they were all convinced that the U.S. government was going to put in
Death panels.
death panels, and that's
Yes.
because you are saving so much money. And where does that decision process get made? Is it trying to change the behavior of patients so that they want to choose hospice, which I think actually, like if I look at my grandmothers, I don't think either one of them would ever want to be in a conventional hospital hooked up to tubes. They just want to, when it's time, go. But so I guess where does that decision process get made?
So, the thing that people said over and over again to me, the hospice physician said this, sometimes it's the patient, sometimes it's the family, and sometimes it's the doctor who doesn't want hospice. Sometimes the patient, and I saw this in a number of cases, sometimes the patient does not want to die and wants to do anything they can in their power to stay alive for as long as possible. And what was interesting for me from a sociological standpoint, it was from my observations, it was always the people who had lived the longest. 97-year-old man dying of, what type of cancer? He had a cancer. It was going to be a terminal illness. He did not want to die, and he refused to go into the palliative care unit. And he died on the conventional care unit. Sometimes it's the family, and I've seen this, personally within my own family. The family doesn't want that person to die, and allowing someone to go into palliative care or hospice acknowledges that they're going to die. So it's definitely, sometimes that problem. Sometimes it's the physician, and for the physician, it can be for a number of reasons. Sometimes you've built this relationship with this person. You don't want to admit failure. Death is failure in our current medical model. It's not normal, but 100% of people die. So how do we instill that into the medical training? You aren't trained to help someone die. You're trained to help someone live. So it's a very difficult thing for physicians sometimes. And then there a number of times that question was raised by palliative care and hospice physicians: are the conventional physicians somehow getting money to keep that person in the conventional setting longer? I can't believe that someone would really do that. I don't know. That's my own personal. I can't believe a physician who typically goes into these healing practices to help people would really do that. But it's a question that's out there.
You mentioned like we all died. I remember John Maynard Keynes said, in the long run we're all dead. But kind of getting to this, I remember so long ago I read an article. It's a journalist talking about her family, and her father. He talked about how the system is meant to keep people alive. Well, hospital and medical facilities kept on trying to keep her father alive, and they had a pacemaker put in. And they kept on trying to keep him alive, but his brain had really kind of soured, and her and her mom were like, he's not. It was really, really difficult, and they lost control of their own family member.
Yeah.
He was alive, he was breathing, but he wasn't really there, and it was really painful for them.
Sure, yeah, and that's definitely one of those cases where it's the physician. And in those situations, it seems that the patient and the family have the option to. You can ask for hospice yourself at any time, but you don't know about it. Or you're told about it in a way that is inappropriate. Oh, palliative care, that's for people who are dying. Instead of, this is something that can help you. So yeah, physicians can, I think it is that failure, that fear of failure. You're failing that patient. at least in my experience, that is why sometimes patients just end up staying there for a long time.
You should like rename palliative care. It seems kind of complex. Doesn't seem to really connect to people.
Yeah, I know. It's
It's like palliative care. What's
yeah.
that?
What is that? What is that? And that's definitely a question. Yeah.
Hi, my name is Steven. So I was wondering if any thought is given to blurring the boundary between conventional and palliative so that it doesn't become a death sentence to make that transition. So
Yeah.
you can go into palliative care but there are therapies there that you might survive.
Yeah, well, so at the national level, this is something that is happening. At the local level where I was, it was something that the physicians in palliative care were trying to push for this, but it was not working yet because they really hadn't been able to, really push their idea upon other patients. But the idea is that if you are diagnosed with a life-limiting illness, doesn't necessarily mean you're going to die. But if you're diagnosed with cancer, it could be a terminal cancer, you immediately get placed with two physicians that are working together. This is part of the problem, how to have two physicians that are actually coordinating care with each other effectively. But one physician is your oncologist and the other physician is your palliative care physician. And it's kind of this wedge-shaped idea where you have, here's time increasing, and this is palliative care, and this is conventional. In the beginning, conventional care is driving the system, and palliative care is just there to introduce the idea that eventually I'm going to be helping you a lot more. And then as time goes by, you need more help with your symptoms. I'm going to increase. Now we're 50-50. You're getting your chemotherapy, and now you're also getting a lot of supportive help in quality of life, making sure that you're comfortable, making sure that you can still do the things that you want to do. And then by the time you die, palliative care is 100% in the driver's seat. And this is something that is being proposed, but I don't know if it's happening effectively yet. But I like the idea. Yeah.
Well, and this is assuming that you go to death, and there's,
Right.
how do you deal when you've got
When you have something that's like a dementia type of thing where you're going for a long, long time, you need a lot of conventional drugs potentially to help you out. To maintain your quality of life and your mental capacity, but could you also be getting palliative care? Probably, because palliative care is a lot of social help, psychological help, things that are supportive of your well-being overall. So I think that it could work in a long-term situation as well.
You mentioned how EPA does not have guns, so I just wanted to ask. I forgot what the regulation law is that would affect hospitals' hazardous waste. But did you see the hospitals going according to the EPA regulations?
No, not at all, because the EPA doesn't have any enforcement.
Yeah.
Yeah.
Well, usually it's a lot of enforcement come to like local agencies, but.
Yeah. Well, and that was interesting because in terms of waste, if for example infectious waste got into the municipal waste stream, there was threat of a fine. There was never actually a fine that I saw. But more so, what would happen was that the waste handler would monitor that hospital for the next 2 months to make sure that nothing entered the waste stream that shouldn't be entering the waste stream. And so it was kind of like a probationary period. And typically, they cut down on that stuff because they could be fined huge amounts of money. But yeah, I never actually saw a fine happen.
Well, I'm going to say I think lots of changes occurred because of Fletcher Allen. It is an incredible system now, and it's actually fines of $10,000 for each occurrence and that sort of thing, and they are levied up. And so there's a significant, and then, the cost of just general waste versus medical waste versus such and that sort of stuff. So it's one of those things that, and you're trying to get stuff to the lowest amount of waste, and they're fining you $10,000, $20,000 an occurrence. And so, I'm going to say I think Fletcher Allen has an incredible facility for monitoring its waste. Not that all facilities do that, but they are levying fines.
Excellent.
That's self-enforced?
No, it's what's that for?
It would be a local waste it would be like the local, agency, kind of like the DNR, Department of Natural Resources type of thing.
Different DNR.
Yeah, yeah, yeah. Do not necessitate is the other DNR. So we only have a few minutes left. I'm sorry, I've kind of been going along with my stories here.
This is great.
Let me see, so just for this part, looking at the pharmaceutical information, the part here that is of concern is that in hospice and palliative care, no IV chemotherapy is administered. It's actually, it could be in palliative care, but really transitioning, in this situation, you're transitioning away from the aggressive care. But in the conventional care, what it was equaling was 1 dose per nurse. Every nurse, every day is giving chemo. So they have a lot of opportunity for exposure. Then the pharmaceutical waste question, we kind of got at that. We either have the hazardous waste incineration, which has implications because for this place, there are only a few accredited hazardous waste incinerators in the country still. They've been decreased drastically. Right now, where this place was sending their waste, it went to Fort Arthur, Texas, was where the incinerator was. And this was all of these incinerators are questions of environmental justice. They're all cited in poor black communities. Once the stuff is incinerated, now you have toxic ash. Where does that go? That goes to Emila, Alabama, which is the largest hazardous waste dump in the country. Also a place of poor black community. And at the time when this dump was cited, it was, I think the population was around 90% black, 90% African American, and there were absolutely no black representatives on the city council, town council that cited it. So there's just, places that the communities lack power, so that's a huge question. But then at hospice, you're sending things down the drain. So, the question is, which is worse? I don't know. How can you tell which is worse? They both have their problems. At least in the incinerator, you know where it's going, and you know where it ends up. Maybe that's better? I don't know.
Though some of it ends up in the atmosphere.
Absolutely. If you don't have your scrubbers and everything, yeah, absolutely. Okay, so here we are. We're finally at the governance part. And we only have a few minutes left. I'm sorry. So, all right, here, when we're talking about that manufacturer, the medical supplies, where are they coming from, where is it going? The thing that I found most interesting for the amount of waste that's coming out of these places is that infection control policies outweigh any sort of environmental concern. So for example, a typical scene after someone dies in a conventional or palliative care setting would be that you would collect, there would be 3 bags of garbage, like 30-gallon bags of garbage. 2 of those bags would be completely unused items. Things that were brought into the room at the moment of death because you're trying to help that person and save that person and lengthen the life, whatever you can do. You bring all this stuff in, you don't use it because you didn't really need that one or that one or that one. But now it's in the room, and so it's considered contaminated, and it is infectious, and it has to be thrown away. So infection control policy, huge governance question. At the hospice, one part is that there is no emergency in hospice, so they aren't bringing as much stuff in. But the other thing was that they were limiting the amount of stuff that comes into the room in general on any given occurrence. And then also they had set aside a space in each patient room that was a clean area. So if you brought something in and you set it there, and you didn't need it, when you left the room you could take it back out and reshelve it. It's not contaminated, it's not considered contaminated. Huge impact on the amount of waste that was being thrown out, that 2-to-1 amount of waste that was coming out of those places. But they also had set up this thing for donating items that were contaminated. A popular thing was depends on undergarments. So adult diapers, you bring in this huge bag of adult diapers, you open it up, you only use one. Now you have this bag, the patient dies, what are you going to do with all those, 15 other diapers in there, they would donate it to a local organization that would then take it and distribute it around the world, basically, to other developing countries that needed medical supplies. But now, there's kind of an ethical question in that because, well, it's not good enough for us here, it's contaminated, so we're giving it to someone else. So what's the risk that we're passing along to another community?
Transportation costs.
Transportation costs, absolutely, yeah. For the occupational and community exposure, so talking about the guy in the grinder, part of the problem was that they aren't seen, those people aren't seen. There's this huge division of labor between the nurse who throws it in the bag, the housekeeper. There are nurses and housekeepers who have been working right next to each other for 5 years. They don't know each other's name because it's a division of labor and lots of other social things going on there. But then even worse, that person who is down the road after transporting it down the road to the infectious waste processing plant, the housekeeper has no idea where it goes. There's no way of knowing who that person is, and because you have that division, you don't know that the thing you just thrown in there is going to put that person at huge risk. You don't even think about it. For the chemo, when you're spiking that bag, you have your blue gown on so that you're protected because it's the paper and plastic protecting you. But you should also be wearing goggles and gloves and all these other things, maybe even like a huge mask or a hood, something to protect you from those things. But a lot of nurses chose not to wear the things that they didn't have to, the things that were recommended, but they don't have to wear them. Because when they walk into a room geared up like that, the patient says, whoa, what are you putting in me? You can't even touch this stuff. So it's a question of patient satisfaction, which comes back to the hospital. At the end of that patient's stay, they're going to send in a survey that says, how satisfied am I? And if that's impacting the rating that the hospital gets, the rating goes down, the income goes down. So there is a huge question. And then for the pharmaceutical control, I already told you the quote of the DA, they have the guns and confine us versus the EPA. So the concern more was for narcotics, making sure that narcotics were going down the drain so that somebody couldn't get a hold of them instead of what's happening once those things enter the water. So it's really all about the trade-offs. Everything, environment and human health don't come into play at all for concerns. It's the cost, it's the income, it's the patient satisfaction. So then just to, another time, I'm just going to say like one or two more things.
Yeah, that's fine.
The idea is that what we're seeing here is that conventional care has the highest impact, just based upon the amount of stuff and what it is that's going in. So hospice and palliative care, lower impact, but this problem we've been talking about, patients aren't getting in there. You have the eligibility to be in hospice for 6 months at least. A lot of people are on there for 2 years because you can just keep getting readmitted to it. But the median for the length of stay is 21 days. So patients are only in there for the final 3 weeks of their lives. A lot of people are only in there for a few hours. You get transferred, you get dumped. A lot of people say you get dumped into hospice because they're on their way out. You're going to dump the patient into hospice. And that just that's not what hospice is about. Let me show you. Okay, so here are the reasons why. Yeah, go ahead.
I think it's hard for someone when you're down to I think your final month.
Mm-hmm.
I think but when you're 6 months away from your it's a lot of time. I think people they're still hopeful.
Absolutely, absolutely. And how do we temper that hope in terms of what is it that you're hoping for? And how do we make sure that we display hospice in the way that it is? And so this is, all right, all three of these places had impact.
We're hoping for that that miracle cure that you hear about on the news. That's you don't hear about everyone who's dying. You hear about that one person who's had the miracle cure, or for whatever reason, they turned around when they were supposed to. They're living 5 years and they were supposed to have been dead in 2 months.
Well, and even we were saying before, DNR, do not resuscitate the other DNR. So at end of life, it's really appropriate for people who have a terminal illness to sign this waiver that says, do not resuscitate me. I don't want CPR when I die. A lot of people will not sign that. They want CPR, they want everything that can be done for them. But it's because media portrays that you're gonna get CPR, you're gonna be okay. What the reality is, 4% of people who get CPR actually will survive if they have a terminal illness. And if you are gonna get CPR, even if you do survive, or if you don't survive, you're gonna have broken ribs, you're gonna have a lot of pain. It's gonna be really traumatic to your family to see this, especially if you still die. So this huge media impact upon what's happening here. But here's the thing that I find most interesting to me. So we see that hospice and palliative care definitely have these lower cumulative impacts overall. We don't want to go into hospice because we're afraid of dying. But if we went in there, if we transfer in, when we have the time, if we transfer in there 6 months before we actually die, a lot of things happen. We would prefer to not die in the hospital. Hospice allows us to die not in the hospital. We have better pain and symptom management if we're in hospice because the physicians are trained to use narcotics more effectively. A lot of physicians in the conventional setting are afraid to use narcotics to the point that they are actually needed to be used to control pain when you're at the end of life. Your family is happier when you are in hospice because they're getting a lot of social support that they don't get in the conventional setting. You won't be in the hospital for as long, and you can actually live longer. This was a study about, I think it was 6,000 case controls. So a patient and then a person who was a patient in hospice versus a patient who stayed in conventional care. Same diagnosis, they matched them up and they followed them through time to see what happens. I think it was about 6,000 people who were followed. If you have chronic heart failure, no, CHF, congestive heart failure, you live 81 days longer if you're in hospice. If you have lung cancer, 39 days longer if you're in hospice. Pancreatic cancer, which is pretty much a death sentence right now, you live for 3 weeks longer if you have hospice. Hospice is not necessarily a death sentence, but we equate it with being that. So